Carotid artery stroke and manipulation. In the news once again is a story related to a proposed association between cervical manipulation, stroke, and death. This story in particular was headline news because it involved a young social media star. Even more enticing for the news media was the conclusion of the coroner, who stated that chiropractic manipulation was the cause of death. This case was the more commonly reported vertebral artery dissection, and it brought chiropractic to the spotlight once again, with the usual speculations and accusations by vested pundits. Timely, then, is the study we will review regarding the other cervical artery, the carotid artery. So as rare as VBA is and its association with manipulation, more rare is any apparent association between carotid artery involvement and manipulation. The study we will review is a large population case control crossover study similar in approach to the hallmark Cassidy et al. Study in 2008 examining manipulation and vertebral artery stroke. The study is entitled Risk of Carotid Stroke After Chiropractic Care, a population-based case crossover study by Cassidy et al., published in the Journal of Stroke and Cerebral Vascular Diseases in 2016. Some important distinctions regarding carotid artery dissection versus stroke. Cervical artery dissection accounts for only 2% of all ischemic strokes, but accounts for 8 to 25% of stroke in patients younger than 45 years. Remember, though, that the cervical artery designates a broad category, with vertebral arteries and carotid arteries as subdivisions of that. Remember also that dissection is tearing of the artery and not the stroke. There are two types of carotid artery dissection, traumatic and spontaneous. Spontaneous carotid artery dissection accounts for 10 to 25% of stroke in patients under the age of 45. 70% of patients with carotid artery dissection are between the ages of 35 and 50. More than 75% make a full recovery. The risk of recurrence is 2% in the first month and 1% per year thereafter. Regarding the association between cervical artery dissection and stroke-related manipulation, 5 studies have been published. 2 used Canadian Health Services data, and the other used California stroke registries, Medicare Advantage data from the U.S., and cervical artery dissections seen at 18 neurology departments in 8 countries. Only 1 study included results specific to carotid artery dissection strokes and concluded they were not associated with neck manipulation. Recently, in the periodical Stroke in 2014, the American Heart Association and American Stroke Association registered a concern regarding manipulation and cervical dissection, literally stepping on the toes of their own logic. Quote, although current biomechanical evidence is insufficient to establish the claim that chiropractic manipulative therapy causes cervical dissection, clinical reports suggest that mechanical forces play a role in a considerable number of cervical dissections, and most population-controlled studies have found an association between cervical manipulative therapy and vertebral artery dissection strokes in young patients, unquote. And notice no statement regarding carotid artery dissection and stroke. The likely reason for the assumption that manipulation causes stroke is termed protopathic bias. This bias is seeing a healthcare provider during the prodrome of a condition before it clinically manifests into a full presentation, without giving reason to further evaluate or differentiate from common causes. In the case of dissection, it's the presentation of neck pain or headache prior to progression to stroke. And remember, there is no clinical test to detect during this phase. We can see how disarming and confusing the presentation can be when we look at the referral areas for first the vertebral artery. And then the internal carotid artery. So although each major artery supplies different areas of the brain with distinct neurological signs and symptoms when stroke occurs, this is dissection. These areas of pain referral overlap with many common headache types and may not reach the threshold of concern unless it's described as new and the worst headache they have ever experienced, and certainly if neurological signs or symptoms occur, this crosses that threshold and the patient is in need of immediate referral. So to the study. What is a case control crossover approach? Well, this is a quicker, less expensive approach than prospective studies. That's because patients' health records are reviewed after the event with a chosen time period. In the case of this study, that was 9 years. This is appropriate for rare occurrence disorders and when there is a transient change in risk. The crossover approach uses the patient as their own control when they don't have the disorder. When studying the risk association between or among suspected factors, researchers can proceed forward in time using a cohort study and eventually know which participants developed the disease or event who were exposed to a particular risk factor or set of factors, and then compare them to those who developed the disease who did not get exposed and see if exposure increased the occurrence. In the retrospective approach, also called case control, researchers look back in time to patients' health records for those who had the outcome, in this case a stroke or dissection, and then see who were exposed to the risk factor. In other words, when you move forward in time, you know who is exposed to the risk factor, but you don't know who will develop the disease or event. The reverse is true of a retrospective study. For a rare event like vertebral artery dissection or carotid artery dissection, perhaps millions of patients would have to be followed for years to detect enough cases to provide enough data for analysis. Finding the occurrence retrospectively is far easier but less scientific. Bias and error are more likely, but with evidence-based approaches you can only rely on the most available and feasible study. Certainly higher in the hierarchy of evidence when compared to the few published case studies or case series reports, assuming it's carried out appropriately. The researchers used administrative data from the Discharge Abstract Database from the Canadian Institute for Health Information, the Ontario Health Insurance Plan Database, and the Registered Persons Database. The DAD is a record of all hospital discharges. They looked for cases tagged by ICD codes for carotid artery stroke, stenosis, or occlusion. There was a strong attempt to exclude any confounding factors, such as those with other stroke or previous dissections. Because it's likely that patients seek care while in dissection due to headache or neck pain, researchers identified specific visits to chiropractors for neck pain or headache-related services, utilizing unique codes for subluxation, sprain strain, neuritis or neuralgia, radiculitis, or headache. And for the PCP visits, they utilize ICD-9 codes for headache and neck pain, including tension and migraine headaches, intervertebral disc disorders, fibrositis, myositis, whiplash, sprain strain, and other traumas associated with the neck. Researchers utilized 4 types of exposure for comparison: no exposure, which was the control, a DC-only visit, a PCP-only visit, or both DC and PCP visits. They even excluded PCP visits that occurred on the same day of the stroke, given the patient may have sought care. They found 15,523 cases of cervical artery dissection and compared them to 62,092 control periods using exposure windows of 1, 3, 7, and 14 days prior to the stroke. Of the total cases that met the inclusion-exclusion criteria, 35% had received only PCP services, 1.2% had received only DC services, and 0.7% had received both services. Older cases received more services coded for comorbid conditions, especially those seeing an MD, and those who saw a DC tended to have fewer comorbidities. Too few cases saw both practitioners in the 7 and 14-day exposure periods to calculate the estimate. So the bottom line, for all DC and PCP visits in those less than 45 years of age, there is an association with stroke for both groups, but no significant difference between PCP and DC patients, and no cases who saw both practitioners less than 7 days before the stroke. For stroke cases 45 years of age or older, there is no positive association with chiropractic care or with the combination of DC and PCP care. There is a consistent but weak association with PCP care in the older group. But was there a higher occurrence if patients presented with headache or neck pain? When researchers restricted the analysis to visits that were coded for neck pain and/or headache, the odds ratios increased considerably for all DC and PCP exposures in those less than 45 years of age, with one exception. Although the point estimates are different for DC and PCP visits, there is no statistical difference between them. It's postulated by the researchers that the weak associations seen between PCP care and stroke in older individuals are due to comorbid disease, and that sicker, older individuals are more likely to consult a PCP than a DC. So what do we know at this point? In a review published in the Journal of Manipulative and Physiological Therapeutics in 2015 entitled The Association Between Cervical Spine Manipulation and Carotid Artery Dissection, a Systematic Review of the Literature, they state, quote, "The incidence of internal carotid artery dissection after cervical spine manipulation is unknown. Although several case reports and case series raise the hypothesis of an association, we found no epidemiologic studies that validate this hypothesis," unquote. And we know that about 80% of individuals have pre-stroke complaints during dissection, which may include neck pain or headache pain in the orbital-facial or temporal region. They may have, in the case of carotid artery dissection, Horner's syndrome, amaurosis fugax, which is a temporary loss of vision due to decreased retinal artery supply, cranial nerve involvement, or a complaint of a whooshing sound type of tinnitus related to the dissection. So what are we to do? Refer any patient with atypical headache or neck pain with associated neurologic symptoms, whether the history is spontaneous or traumatic. Remember that it is reported that recurrent headache or neck pain after dissection occurs and may last years after the event. All patients who have had a carotid artery dissection should see a vascular specialist. Monitoring CT angiography or other imaging is used in all cases who survive. Higher risk patients for spontaneous carotid dissection include those with fibromuscular dysplasia, Marfan's, and Ehlers-Danlos syndrome vascular type 4. Also be aware that traumatic carotid dissection may occur after whiplash injury. Unfortunately, diagnosis for field practitioners is not possible given there is no in-office test, so that only a high level of suspicion directs the patient to appropriate imaging and diagnosis. So we can only remain vigilant, but may be caught in the unfortunate confluence of patients with dissection seeking our care. And remember, rare remains rare only when it doesn't occur to you.